Our next presenter will be Dr. Andrew Seaman.
All right, hi y'all. I'm Andy Seaman. I'm a harm reductionist and a researcher and addiction medicine doctor based in the northeast of the US. Most of my work is in Oregon. And I'm going to talk about something we call the dried blood spot test and treat model, or DBS-TAT. And these are my disclosures, the most important of which is the overstuffed burrito. I'm going to overstuff the shit out of this presentation, so hang on, and sorry, I'm not sorry. 3 minutes.
You will be stopped.
Oh, I know, I see you. So point of care, so some background here, the point of care RNA and dried blood spot testing approaches allow us to diagnose hepatitis C without phlebotomy, but at least in the general population of practitioners, especially in the US, the lack of some kind of point of care fibrosis assessment is a barrier to implementation, even though the guidelines say we can move forward without it. The D-Check is a retrospectively validated 5-point questionnaire that we created at Central City Concern, and has a very high sensitivity for advanced fibrosis and decompensated cirrhosis. And CCC is a Healthcare for the Homeless organization. Our Hep C elimination program has screened over 16,000, treated over 3,000 folks in the last 7 or so years, and most of whom are or have experienced houselessness. So there's 2 arms. These are prospective cohorts established for us in June 2021. We have a dried blood spot card very similar to what you just saw, a Hep C antibody, although usually we do point of care first if we're testing in the community, and Hep C RNA, HIV antigen antibody, and the hepatitis B surface antigen. And it's people who had a positive RNA until January of 2023. We would then do phlebotomy for a FIB4, occasionally, or sometimes would do a FibroScan as well, and then we'd treat them. So starting in looks like they didn't quite update my slides. There are going to be a couple errors on this, unfortunately, but starting in January of 2023, we also started doing the G-Check questionnaire at the time of DBS testing. People who had an RNA that was positive, if their G-Check score was less than 10, I'm happy to talk to you more about that score offline, then we would treat them. And with the phlebotomy, if their D-Check was above 10, we would do what we did previously, which is phlebotomy, and then stratify and treat. This is our consort diagram. I'm not going to talk about it. I'm happy to go over it later, and I shared my slides, and these are the characteristics. The main callouts here is that between the 2 cohorts that were roughly the same in size, there were no significant differences in age, sex, gender, housing status, or screening site distribution. And importantly, 92% of them scored less than a D-Check score of 10, less than or equal to, which means we could treat them without having to do additional labs. So the primary outcome, which was pre-specified, was the DBS-TAT increases treatment initiation by about 19%. So this is of all RNAs in our system. So some of them are performed by outside community partners. We had no role in screening them, so they were quite disengaged. And that has a odds ratio of 2.2 for treatment initiation, adjusted by these other baseline characteristics down to 2. The treatment initiation for the people who had a D-Check of above 11, so again they needed the labs, was 53% versus 69 with a D-Check of less than or equal to 10. That was not statistically significant, but again that 53% of folks, like these are people who by definition have a much higher risk of advanced liver disease, and so they were, they have more kind of intrinsic reason why they should be treated or could be treated. And then the DBS-TAT also really importantly shortens time to treatment pretty substantially. So this is reversed. Again, the slides didn't quite get updated, but in the DBS-TAT group, mean number of days was 40, and the enhanced usual care group, it was 105. And we did some linear regression on that and brought us about a 56% shorter time to treatment in the DBS-TAT intervention. So again, looking at the treatment initiation, and I'm just showing that again here, there was no difference in treatment completion, almost 100% completed treatment in both of these groups. You do see though that difference, and I use viral clearance more often, SVR12, that's just all of the people who were tested, regardless of whether they were treated, how likely are they to be cleared at the endpoint of the study. It was roughly the same, and that was almost exclusively due to just missingness in SVR12 data, which we often see when you make the early part of the care cascade easier. It gets harder to kind of retain folks for lab testing later on. Okay, so the take-homes. 90% of folks initiated treatment without lab-based fibrosis assessment. This is not just important because it's easier for folks, but it also, our team is now out there screening people in the street instead of driving them to the hospital for people who have difficult phlebotomy to get them ultrasound-guided labs. It just increases the efficiency of the team. People love it. People love not having to get their blood drawn through phlebotomy. And implementing the D-check through this model increased the treatment initiation, decreased time to treatment, and with similar treatment completion rates. And then again, we still had trouble getting folks in to get their viral loads done for confirmation of cure. And then again, recognizing this is a retrospectively validated tool in our system, I feel very comfortable using this. There were no adverse consequences. I feel very confident in the study for our population, but it needs to be prospectively validated or something like it. I think this tool or something like it would be really important to increase implementation across the board for point of care or test and treat models. Thank you. Yeah.
Thanks, Sandra.